So the learning objectives of today is basically to understand the faulty myth, which we're going to go into, that's fueling the current epidemic of chronic pain. To understand how SIRPA's approach can help people recover from, not just live with, their chronic pain. And also to learn some simple self-empowering strategies to begin your own recovery. So what's the myth? The myth is that chronic pain must be due to a physical abnormality. We're always told back pain, your sciatica is due to that slip disc, look, you can see that slip disc there, etc. But too often in the years that I'm in my 30th year as a physiotherapist now, and too often in those times have the signs never quite fitted the symptom of one prolapsed disc pressing on one exiting nerve. So the myth is that it's due to a physical abnormality, so I'm just going to challenge you to start thinking, well, what if there is another reason for the chronic pain? So part of the reason that I started questioning was that when I considered my patients over the past, and most of these are my patients, the only one that isn't is that one, but this was really just to demonstrate that actually patients will come in all shapes and sizes. They will come in various different postures. The lady over here, she had a severe scoliosis. She has a severe scoliosis since teenage years. She came to me having been off work for 5 months and had pain for well over a year and was told all she could have was spinal injections. She was one of the first patients I saw that made me think the potential for this is enormous, and actually she was one of the patients that made me decide to go over to Dr. Sano and spend some time with him in New York. So then we look at the guy here, Colin. He's on the website. They've all given me permission to use their names. That's why they've given me the photos. Colin here is an Ironman. He's an international triathlete. His core stability is fabulous. And yet other patients I would have, in fact, Jimmy up here is another one we'll talk about. His core stability was shot. They both had pain, and yet we're told time and time again that core stability is so important, and that if you've got good core stability, you'll get rid of the pain. The state of your muscles has no effect on whether you have pain or not. And when I set up my own business, I then started realizing that people were coming to me who'd done all the Pilates, all the core stability, and then were coming to me for pain relief. Now, I'm not saying that exercise and Pilates isn't good. What I'm saying is that actually it's not going to stop the pain on its own, because it's addressing the symptoms, as most treatments do, rather than the underlying cause. So we've got this guy here. His core stability was beautiful. He had a straight, upright posture, strong, very supple. He spends an hour doing yoga every single day. He spends more than an hour doing meditation every day. He had pain all over. He had back pain, he had neck pain, he had hip pains, and had anxiety and depression. I really thought he'd struggle. He did fantastically well. We've got the young girl here, Megan. She is a national diver. Her back went when she had been spotted for the Olympics. She was being seen by the Olympic physiotherapists. She was, for 2 years, had a lot of treatment. And then eventually her mother came to find out about my work. Okay, and I'm going to go back to her in a little while. Chris, this guy, is somebody who came to me after he'd retired. And although he'd had aches and pains throughout his career, they became a lot worse after he'd retired. And that, again, we're looking at the underlying emotional causes here. And retirement is a massive change for people. And he had a very high-powered job, and suddenly he hasn't got a role anymore. So that actually can be a trigger. And lastly, Marie here. This is Marie, who was sleeping for more than 20 minutes. And up until, for the previous 6 months, she'd not slept for more than 20 minutes. She was on all sorts of medication. You can see that the whole of the spinal canal, uninterrupted all the way down. You can see the discs here, okay, nice plump discs with the nucleus inside. And you can just about see these nerve roots coming down here. Now, you would look at that MRI scan and think, okay, that's perfectly normal, no abnormalities, no pain. Wrong. There are so many people who have MRI scans like that, perfectly normal scans, but who have had chronic pain for years. Then we move on to Marie's MRI scan. Now, if you look at this, you can see compare the spinal canal there, completely flowing right the way down, and here there's a real disruption. And this is the level of her prolapsed disc. And she was told she had, well, the scan report said that she had a massive prolapsed disc which was compressing centrally on the spinal cord, you can see, and the exiting S1 nerves on both sides. And you can see here, but there is obviously a break there where the nucleus has actually come out of the disc. And she came to me with all the symptoms that you would expect of somebody who had that sort of picture. Severe back pain, horrendous sciatica, numbness. She couldn't stand up on her toes, so she had muscle weakness. She'd lost her ankle reflexes. But she didn't have problems both sides, equally both sides, despite the fact it said it was compressing both sides. It was one side. Luckily, just before she got the results of this scan and was told she would need surgery, she'd come across my work. These are the graphs when she actually managed to get to me. These are the graphs that she did at home while she was on the program with me. So over a period of 2 months, you can see the medication here. She's on an opioid and 4 different types of painkillers. And it shows the level of painkillers she was taking them and how they reduced as she went along. It showed her level of pain, score of pain out of 10, and over 2 months gradually reducing down. I didn't do any hands-on work with her, none at all. This was her understanding the underlying causes of her pain rather than believing that the pain was purely due to that prolapsed disc. And that was a challenge, obviously, because she was new to this. So it was challenging at first. It took her longer to get rid of the numbness and the muscle weakness, probably because of the doubts that she had in her head. But this was now 3 years ago. So this is Marie soon after. It was, I think, 3 or 4 months after she first came to me with one of her children. She was actually doing a sponsored swimmer. She's continued to raise money through usually swimming, okay, and raises money for Mind. So she's just one of the ones I wanted to demonstrate because she's a classic in that we've got those fabulous MRI scan results. She did those fantastic graphs which enable us to see her own recovery from how she saw it as well. So what I want to do is explain why Marie can recover despite the fact her MRI scan showed that. And this is just one of the studies, and there's loads of studies that actually demonstrate just as many people, whether or not they have pain, have prolapsed discs, stenosis, and various spinal degeneration. So this one, these are MRI scan studies into people who don't have pain. And the conclusion was about 1/3 of the subjects were found to have a substantial abnormality. So they're looking at people who don't have pain, and yet they're showing that 1/3 of all the subjects actually had a substantial abnormality on the MRI scan of their spine. And actually when you look at the over 60s, 57%. And that's not surprising because we wear and tear. As we get older, we degenerate. It's normal signs of aging. Dr. Sano would say it's actually like grey hairs of the spine. This other one, okay, looking again at degenerative disc disease and pre-existing spinal pain. And again, degenerative disc disease, as seen on imaging, is not a painful condition. I could have shown more slides on this, but I didn't because it would just bore you. But this is just a couple, okay, that demonstrate this. So moving on, as a physiotherapist, what surprised me, looking back, once I know what I know now, looking back, in the early 1990s, the EEC manual handling regulations came in. Now, as a physiotherapist, we used to do lots of bending and lifting, a lot, okay? And over the years, we were allowed to do less and less. And I used to have back pain. I used to have neck pain. I used to have all sorts of things, but the back pain I always used to blame on my lifting and handling. Well, obviously, I've just spent, 20 odd years lifting on the wards and in the community with people in the community because we didn't have lifts, so we would actually lower them down to the floor, drag them back up again, okay, until we weren't allowed to do that anymore. But there is still an increasing number of people developing back pain, and yet now we're hardly able to lift anything at all. We're so limited by these regulations at what we're allowed to actually lift. So it doesn't really make sense. You would think that now we're not allowed to lift as much, nurses aren't allowed to lift, physios aren't allowed to lift, people in various different companies, therefore pain should at least be, back pain level should at least be levelling out, or the number of people with pain. The other one is the display screen equipment regulations. This also, the regulations are all about having the correct height of desks and things, and I know this because a few years before I came across this, I went on one of those courses as a physio to learn, okay, what's the correct height? You've got to make sure you can see the screen right in front of you, you've got to make sure that you're not twisting around and everything. And yes, that's all very good advice, and it's good to get up and move around, but actually back pain cannot be caused by sitting around too much. RSI is not to do with repetitiveness. What happens is that people don't look at what else is happening in their lives when the pain begins. So the other fact is that despite the fact that display screen equipment regulations came in, again around about the same time, there's been no reduction in people with RSI. In fact, it continues to rise, the number of people who have RSI and back pain. Whiplash. This is something called demolition derby. These are competitions in America where they go around bashing each other and actually making sure that they do as much damage as possible. But the fact is that in a research study that looked at 40 drivers who were demolition derby drivers, 38 of 40 had pain lasting less than 21 days after an average of 156 collisions. So this isn't just one accident where you're shunted from behind and develop whiplash. These are people who have high-paced crashes, head-to-head and from behind anywhere, and yet 38 or 40 of them have never had pain longer than 21 days, despite the fact they had so many collisions. In Lithuania, there is no such thing as whiplash. They've never heard of it. Okay, and I haven't got time to go into the studies there, but actually there is no such thing as whiplash there, and yet in the Western world, in Norway has a huge rate of whiplash, Britain, it's escalating, and yet the majority of people don't actually have the force of an accident that would actually really cause damage, or more than just a bit of an ache for less than 21 days. So moving on to another study, the work environment. What they found recently was that lack of decision control, lack of having empowering leadership and fair leadership have been found to be the most consistent predictors of back pain. So this was actually looking at psychological, social and mechanical predictors of back pain. And yet none of the mechanical ones came into it. If you were fed up in your work because you weren't given any responsibility or you weren't being empowered, that's why you would end up with having problems. Okay, those were found to be the main predictors of back pain. This one was a study done with trainee nurses. For 3 years throughout their training and 6 months afterwards, they were followed up. And they were looking again about when did they get back pain, what was happening when they got back pain, were they lifting patients, what was going on. And guess what they found? Again, nothing to do with anything mechanical. The most consistent factor found to predict back pain onset was psychological distress. Psychological distress could be boyfriend issues, girlfriend issues, okay, could be exam problems. And you ask any university doctor, they'll say there are many more of the students that will come and see them in the finals year and just before the exams. And they didn't find it was anything to do with when they were lifting a patient or doing anything physical whatsoever. It was psychological distress, which again backs up what I'm going to be talking to you about. So just as talking back pain alone, the daily cost of back pain in the UK is 1.3 million every day. In benefits, 14 million. And to the economy, 37 million. That's a huge cost, and that's only back pain. That's not fibromyalgia, that's not RSI, that's not whiplash or anything else. So it's a huge, huge problem to the economy. So what is the SIRPA approach? It's based on the concept that physical and or psychological symptoms become the escape mechanism, okay, for the build-up of unresolved emotions. Okay, they build up and there's no outlet. So we're like an emotional pressure cooker, okay, and we go through life and we we cope and we have the British stiff upper lip, and often pain comes from the fact that we are coping so well because we bottle it up and we keep going, we don't acknowledge it. And just think of that pressure cooker, and that valve allows the steam to escape, and it's almost like the symptoms become the escape valve for the build-up inside. No! When I left the NHS and developed severe sciatica and couldn't put my shoes on, that was real. Okay, when I used to get my migraines, and I remember crawling up the stairs at home, having driven from Bradford after work. I don't now remember what was going on at that time, but I remember crawling up the stairs in agony, and if my husband hadn't happened to be at home and given me a painkiller, I would have just probably slept on the floor and not even been able to get on the bed. Okay, this is real. And what we're actually saying is that the majority of chronic pain and other chronic health problems, where it's not cancer, you've got to obviously be very careful and rule out anything more serious. Where it's not cancer, where there's no infection, where there's no fracture or an autoimmune disorder, then I now agree, after working in this field for 6 years, with Dr. Sarno in saying that actually nearly all of the others of everything else in chronic pain is actually emotionally induced, stress induced. And I'll explain how that actually happens. But the symptoms are a result, okay, of unconscious and automatic responses in the brain and the central nervous system. Okay, so it's actually just an automatic response. So let's have a look at this. Basic neurophysiology. We have an emotion. We feel happy, we feel sad, we feel frightened, whatever it is, we have an emotion. We then have neuropeptides that flood the whole of the body through the blood. Okay, they flood the body and the brain. When they get to the brain, they stimulate the emotional part of the brain, the amygdala in the emotional part of the brain. That then sets off a chain reaction causing physiological changes within the body. Okay, that's as deep as I'm getting. All right, have a think about it. People often say to me, well, I'm not stressed, or, okay, I can see I was stressed when the pain came on, I'm not now. Unfortunately, what happens is the physiological changes occur within the autonomic nervous system, and then these nerve pathways become learned, and we can become conditioned to have the pain. But we do know that we can change these pathways, we can change what's going on in the brain. The studies are all showing that now. So, who's ever blushed? We just accept that. We accept that if we're embarrassed, we'll blush. And what's that but the emotions of embarrassment, and I have a clue what the neurochemicals are called for embarrassment, but they flood the system and the brain, and they cause a physiological change in the body, which is an increase in blood supply to the cheeks. How many of you have, maybe before a talk, or maybe before an exam, or doing something you're really anxious or nervous about, how many of you have suddenly realised that you're desperate for the loo, and you keep having to go to the loo? Again, it's accepted response, isn't it? We feel anxious, we might need to rush to the loo. These are all accepted things that actually happen. Sexual arousal. So sexual arousal is actually something that very clearly demonstrates how emotions affect our brain. We all have changes when there's sexual arousal, and especially with a man, you know that if they can't just think, I'm going to have an erection. They have to have the emotion, and then the physiological changes in the body occur. Does that make sense? Okay, so it's not just, it's an unconscious reaction, and it's automatic. All right, so what I'm trying to show here is that all three of these demonstrate what's happening all the time, is that the mind and the body are constantly working together, and they are responding to what's actually happening with emotions in the body. The most recognizable one that people think of is the survival, the fight and fight response, the survival response. And what we're talking about here is that this concept is that it's an adapted fight and flight response. Okay? We don't have life-threatening situations very often these days. All right? It's more often psychological stresses. So if you look at this poor little dog that's being attacked, okay? First of all, the different fight and flight response, the various choice. We're just going to stick to the main three here, which is the fight response. The brain will cause changes within the body, which will allow the body to be prepared to fight. Okay? So to actually fight against whatever it is that's actually threatening their survival. All right. Another one is the flight. So the fight and flight response. Looks like this little dog is on the verge of fleeing. But again, it's an automatic unconscious response, quick, let's go. There is a third one, and that's the freeze response, which is like rabbits in the headlights. So again, all those are an automatic unconscious response, and we've all had that when we have if somebody jumps around the corner and says boo. We have that automatic response. Our heart rate will quicken up, the blood supply goes to where it's needed in the muscles to get you away, your airways open up so you can get more oxygen. All these different things happen in the blink of an eye. So these are what's happening all the time, and the brain is causing that to happen due to the response to the emotion. So the modern stress, they are mainly psychological stresses, because we don't often have lions coming around the corner or somebody, hopefully not with a gun. Often they are more psychological stresses that we have. But our perceived stress is not just what's happening to us in our lives, it's 10% of what's happening, 90% how we deal with that. And you'll know that. Let's say you've got 3 people who are made redundant, each person will actually respond in a completely different way. But how you respond actually has an effect on how much stress that you perceive. And unfortunately, this is the cause of self-induced stress. So for example, things like, do you ruminate? Okay, do you go over and over things in your head? All right. Do you overanalyze, overthink? Oh gosh, that's a big one in patients I see. And sometimes you need to analyze things, sometimes in your job, but then you need to recognize that when you're causing yourself stress when analyzing. Are you self-critical, a perfectionist, a people pleaser, a coper, conscientious, ambitious, that sort of thing? So they're good things, but unfortunately what they do, if you don't recognize the pressure that you're putting on yourself because of that, then that can result in this being added again to this emotional pressure cooker. So the main underlying cause of symptoms in this emotional pressure cooker we're talking about, okay, it could be current life stresses, responsibilities. Having responsibilities that, maybe you are a people pleaser, you want to be liked, you're very conscientious or whatever, but actually, and you take on things, but then you find you take on too much, and then that becomes a bit of a burden, too much of responsibility, and that causes you pressure. It could be the general life stresses like divorce, moving house, all the things that they say that are the most stressful things to do, children going to university or leaving home, that sort of thing. Any change is a stress, and then it's recognizing, we would talk about how you then deal with that. So that's the current stuff. Then we're actually looking at even childhood or just past stresses. I actually work with people as a physiotherapist, because I don't counsel and I'm not a psychotherapist, but I am working with their emotional issues that they've had in their life, or encouraging them to look at it, not necessarily in a safe environment, rather than having to counsel. Because sometimes what that does, it keeps you there if you go over and over and over things. What we need to do is get people to acknowledge how they felt about things, be able to get to that point where you can put things into perspective and let go and move on, rather than always being triggered by something 10, 20, 30, 40, 50 years ago that's holding you back. So that we actually do, on our assessment, we'll look at current stuff, but we'll also look at past stuff. And moving on from that, we will look at the self-induced pressures, as we talked about, due to personality traits, learned behaviours and beliefs, okay, cultural beliefs or any beliefs that we grow up with. Because these can cause us pressure, cause us to be maybe judgmental, and it just affects how much self-induced stress we put on ourselves. So understanding why we're like that can actually help us to then modify how we behave. So we can't change our personality, but as I say to my patients, if they don't change something, they will get what they've always got. So it's looking at how they can modify their behaviours and their beliefs, and just gradually just changing little things at a time to be able to reduce the self-induced stress that they put upon themselves. The last thing that I include is overstimulation. Too many distractions in this modern world that we live in, where we are constantly at the beck and call of people, with the emails, with phones, with people expecting a response like that. iPods, people, kids texting constantly. So many of my patients, when we look at their day, has no time when they just stop. because they think they're relaxing when they get home. They have dinner with everybody or just on their own on the lap watching the telly and watch telly all evening. That is a distraction from what's going on in here. It's not dealing with any of that. So we encourage people to take some time out to be able to deal with it. Otherwise, what it's doing is it's just ramping it down, okay, covering it up until you actually don't even remember what it might be, and it becomes quite repressed. So what we need is to find time for people to be able to acknowledge what's going on and defuse, and actually, rather than just move on from one thing to the other, take that time to acknowledge what's been going on during their day, during their week, or whatever. So the main aspects of the SIRPA approach. This is all about people taking responsibility. A patient comes to me and I'm not going to then treat them as I would in the past. Okay? So this is about people learning about this and them taking responsibility with support and guidance. In order to recover, you need to fully understand this work. You don't need to be 100% on board with it to begin to make some progress, because actually often when people begin to make progress, then they start, that starts helping them in their belief about what's going on. So we have the SIRPA recovery CD. There are books. There's a number of books these days. Dr. Sano has written 4 books, and there are various other ones. There's patient support websites that patients who've recovered have put together. A huge TMS Wiki website, which is a massive resource. So that's based over in the States. So educational is the first step. Okay, and this is where I say to patients, I can't do this for you, but I can help you recover. Because, and this is why if people say to me, oh, my husband so needs to come to you, can I make him an appointment? No. Okay, because he has to make that appointment. Because I know you cannot convince people about this work. And this is why this might be sowing seeds, this might be a bit challenging, and I've had a couple of patients who came to me 18 months after they first came across this work. Okay, one of them went on and had 2 more bouts of surgery for his back. Okay, so the next step is self-directed and self-empowering, as I've already mentioned, and we have an online program. What's interesting is that some people can recover fully from reading the books, listening to the CDs. I didn't have chronic ongoing pain, but I had a lot of recurring different issues: bowel, back, neck, migraine, knee pain from an old skiing injury. I recovered from all those from understanding the book, but for me it was like an epiphany. It just so made sense. Okay, there are a lot of what people call book recoveries, and that's so frustrating for those people that take longer, and there are plenty of people that take longer, and I wouldn't be in a job if actually everybody just got to better like that. So it's not miraculous, but for some people it just makes sense. They're able to follow the advice that we give them, and they can recover very quickly. But some people need more help. I do assessments in Yorkshire, I do assessments in London. I have the practitioners who do assessments where they live, and we have the online program if people need more support. This helps a patient look at their life, look at their lifeline, and look at what might have triggered their pain, what actually might be involved in their pain, and look at the various links and triggers. And then the online program, as one of my Spanish patients said, thank you for teaching me to live life with less resistance. And that's really what this is all about. Okay, so we've got the online program. I then support people by Skype. So I work with people abroad. I work with people in Dubai and Australia and all over, just when they find that they need help, okay? Because actually, there aren't many of us around. There's me here, and that's why I'm training other practitioners now. There's nobody in Europe. There's a couple in Australia, and there's an increasing number in America now. So we help people identify the links and triggers for their pain. We provide simple strategies, okay, to help deal with the underlying emotions and deal with stress in their lives, all right? And helping you learn to deal more effectively with the stress in your life and basically just improve self-care. Because a lack of self-care, a lack of taking time out for yourself, if you're always helping other people, doing things for everybody else, if you never stop and nurture yourself, do something fun. You know, how often as adults do we just have a real laugh and just relax, let go, and have a really good time? Children laugh, you know, dozens and dozens of times a day. As adults, it's a lot less. Okay, so it's looking at how we can look at our lives and actually improve our own self-care. And we can actually break the learned condition patterns, the learned nerve pathways, and this is what we're doing with patients. I do with them on a day-to-day basis. And beliefs is a huge thing, so we're trying to break those beliefs or open them up to enable them to be able to start recognizing that, yes, okay, they might believe that bending will cause pain because it has for so long, but we have various strategies we can help them with that actually can start breaking that learned nerve pathway and actually then developing more healthy nerve pathways. Some of the treatment strategies we use: therapeutic journaling, lots and lots of research about therapeutic journaling, maybe writing unsent letters to somebody from the past, and then writing a dialogue, getting to the point of putting things into perspective, letting go. There's a lot of health benefits. All the studies have shown that for the past few decades. Meditation, mindfulness, visualization, cognitive behavioral tools, all these generally are effective tools to help manage pain as well. And CBT and mindfulness meditation are used in the NHS for pain management clinics. But that, unfortunately, is what they do. They help people manage pain. Okay? And what we're looking at is actually looking at the whole concept and understanding, no, we're saying stress and emotions don't just affect pain, they actually trigger the pain. And therefore, once the patient and the practitioner accept that, then you've got more of a chance of actually progressing and recovering. Otherwise, unfortunately, they will just remain as management tools. Complete resolution, like I said with Marie, comes with full acceptance that yes, all your symptoms are emotionally induced, but it doesn't mean you can't make progress. So I just want to quickly go through some real recovery stories. These are patients of mine. This lady has become a photographer, so I saw her in 2008. She still keeps in touch. I get birthday photos of her daughter. I get photos whenever they go away just to see what she's doing things that she's never been able to do before or not for a long time. And she was unable to work. She had severe back pain, again due to slip disc, or believed to be due to a slip disc. Jimmy, you might remember from the earlier on, he's somebody who had a car accident, on a motorbike accident actually, and he severely broke a leg. This was 25 years before, okay, one leg shorter than the other. He wouldn't wear a shoe race, so he had one leg shorter than the other, therefore had pelvic imbalance. And because of that, over 25 years, he'd got more wear and tear in his spine, not surprisingly, because it's not nice, and he was probably going to get it anyway, but he probably had more spinal degeneration because he had pelvic imbalance. So he was, again, one of my earlier patients. He used to have 3 or 4 weeks off on sick leave every year, and that would be for 20 years. He had, for 5 years, been to see an osteopath because it gave him 1 day's relief. He came before I went to Dr. Sano actually, and before I actually set the program up, and I gave him the book, yes, I think he was in my DVD, my first one. So he went through the book, I supported him on a one-to-one basis, and since 2008 he's not had any back pain at all. I think he recovered in about 2 months. He's a school caretaker. He has to lift and handle, chairs and tables and all sorts. Okay, he's doing all that. He used to wear a back belt all the time. He used to have to do exercises before he got out of bed. So he's fantastic, and he's another one of those patients that made me realise just how important this work was. Quickly going on, Tracy I told you about, she'd been off work for 5 months, back at work within a week. She's one who literally within a week came back to see me, and I was still doing hands-on work at that time, and we didn't have time the first time, so she came back. And she'd been walking with 2 sticks on the Monday. She came back on the Friday and she just twizzled around, and honestly, she was amazing. Remember, this is me as a physiotherapist, more conventional in those days, having just come across this work. This was profound for me. I was almost in tears, she was almost in tears, but it so proved a point and made me realise that I had to get to New York, and she's still very well. So, just example, this is Megan, the diver. From between 2007 and 2010, her mother worked out that they would have spent, some of it was NHS, but it was around about £5,000 on specialists, spinal injections, scans and therapy, etc. And she came once for an assessment with me. We did the full in-depth assessment. We recognised that, yes, she did fall in the gym. Even if she'd hurt herself at that point, that would have recovered anyway. So yes, she fell in the gym, but it was around the time that she was actually under a lot of stress because she had just won a national competition and was being spotted for the Olympics. can imagine the amount of pressure on a 15-year-old. She was also an A-star student, put a lot of pressure on herself as well. She actually was back diving within a month after coming to me, going off and listening to the DVD, and then doing some journaling and doing some of the suggestions that we made to help her recover. So again, look at the cost benefits. I mean, if we actually had people intervening early on to see, okay, is this an actual injury or is this not? Or even after 3 months, what's going on here? Is it emotionally induced or is there a physical problem? They spent 3 years trying to find out what it might be. They had what they call sequestration, a tiny little blip on the MRI scan, and that they blamed on her pain and depression. She had severe depression when she came to me as well. This is a professional man, a doctor actually. He came to me with a prolapsed disc. He wasn't sleeping more than an hour at a go. And he had severe paresthesia, pins and needles in his calf and sciatica. So he was in an awful lot of pain. He worked out over the previous 18 months on various treatments, he'd spent nearly £5,000. He came on the full programme, and it was a while ago, came and had an assessment, then did the full programme, which then cost $250. I'm still in touch with him, and again I saw him round about 4 years ago, and he's still absolutely fine. And he's one who was a coper, a real coper, and had bottled everything up. And that was then just learning how to deal with it and then learn how to deal with stress in his life. The recovery program, it's an educational and self-empowering program. There's no exercise, no drugs, no surgery. Okay, and that's why I find it so exciting in that it's just so self-empowering for each individual person, but yet we can support them through their journey as well if they need it. So symptoms are a result of physiological changes. So they're triggered by the central nervous system, but as the process is reversible, it means that full recovery is possible. Now some people take weeks, some people take months, some people take years. It just depends on the individual and very much on learned behaviours, beliefs and personality traits as well. Not necessarily how long they've had the pain or how severe the pain, as you've seen from Marie's case. So I know that for many people this is very challenging, okay? All I'm doing here is giving you a snapshot of this work. And I know without a shadow of a doubt as a physio, if I'd come across this work 15 years ago, let's say, I would not have been open to it, I wouldn't have been ready. I was looking for an answer, and that's why I was ready when I came across this work.